Hello and welcome. I'm Peter Suzuki, publisher of Check Rare. Over the past decade, few areas of medicine have seen as much progress as spinal muscular atrophy, or SMA. Advances in disease-modifying therapies have fundamentally changed the outlook for children living with SMA, leading to improvements in survival, mobility, function, and quality of life that would have been difficult to imagine just a few years ago. At the same time, these advances have challenged clinicians, researchers, patients, and families to rethink what is defined as successful outcome in SMA care. In this series of videos, we'll hear from three experts who offer unique perspectives on how the treatment landscape has evolved, how expectations for patients have changed, and whether our current measures of success are keeping pace with these remarkable advances. We begin with Dr. Nancy Kuntz, a pediatric neuromuscular specialist at Lurie Children's Hospital in Chicago. Dr. Kuntz discusses how our definitions of success and normal development in SMA have evolved since the introduction of disease-modifying therapies. She also explores an important question. As patients' outcomes improve, are our current tools for measuring success keeping pace?
I'm Nancy Kuntz, a child neuromuscular specialist. I work here at Northwestern Feinberg School of Medicine, so it's the Lurie Children's Hospital of Chicago. I've been in this field for a number of decades now, and I've had the privilege to watch the change in our understanding and the treatment of SMA. When I first started treating children with SMA, we were making the diagnosis by muscle biopsy, and then the gene was identified, and the clue to what made early onset versus later onset, or the old type 1, 2, and 3, based on the SMN2 backup copies. And finally, now some treatment. And it's been a very exciting change. We've been part of the revolution with families to get newborn screening done so that treatment can be brought in early, and that makes a big difference. So it's been a very exciting time, but also a very demanding time, both for medical sites as well as families. I think now that there are treatments available, parents and individuals are expecting themselves to be cured, to have it all together, to have something that will make everything not be a problem. And we're still in the infancy of this new treatment phase. We don't have all of the answers about which individuals are at most risk, which are going to be most challenged and require combination therapy or more intensive therapy or something like that to produce the improved outcomes. We also have the incident population of all the people who have SMA, who now have access to some treatment, but a persistent motor impairment and a need for a lot of support and a lot of good guidance about what can be done to treat them, even though it isn't early in the course of their disease. So it's a very wonderful and exciting time, but also one that has a lot of challenges. As we try to evaluate and do a clinical trial or initiate a new treatment, one of the things that's needed is to have some objective data, not just that it feels good or people feel a little bit better, but to have some either biomarkers, biochemical blood tests, or X-ray change, or a change on a motor scale score, something that a physical therapist or an evaluator might administer. But the problem is that those scale scores provide a lot of information, but they're not relevant to everyone at every stage of the disease. So obviously different kind of scales have to be made for infants who can't cooperate and who are just learning, having myelination of their central nervous system so they can do some of the tasks. And then when you have older children, they can cooperate and collaborate with the scale scores. But one of the things that has been most challenging as well as heart-wrenching for me is that sometimes the people who control payment of treatments want to have all the patients who receive a new treatment show the same kind of progress on the scale scores that the individuals in the original trial did. And that's difficult for several reasons. One is that any new clinical trial is done to be as efficient and effective and cost effective as possible, meaning they try to get a very tight, similar, homogeneous group of subjects so that there are very few variables. And the only variable is the new medicine. But the intent in those is never to imply that those are the only individuals who will ever benefit from a treatment. One of the challenges many of us have faced over time in the last decade is to try to find ways to introduce the therapy into individuals who weren't perfect subjects for the original trial, to demonstrate to the world and to the insurers that there's still positive benefit to be had for other individuals with SMA. So, for example, I've had some individuals who were completely excluded from all the trials. They were individuals who had very little motor independence. They were non-ambulatory, could not sit independently, could move their hands and feet, but not much more. And so most of the motor scales don't have very many items, don't have very many points on them that relate to the kind of movements these individuals can make. But with treatment, for example, during that period of time when a new drug application has been put in to the FDA, there are times where the companies will allow what they call an expanded access program, where on protocol and under ethics review board at your institution, you can offer this drug with safety monitoring to individuals who didn't meet the original inclusion criteria. So we always made sure to take individuals who were not eligible for the original trials and make sure that they, if the family was interested and willing, had the treatment. We had some individuals, as I mentioned, who had very little independent mobility, but for whom some of these treatments made a huge difference. So, for example, an individual might go from being able to operate a joystick for a moment or two with their hand and wrist to having the range of motion and the strength and endurance to use that same joystick all of their waking hours for anything they wanted to do. Control environmental controls like lights and music, to control a power wheelchair, and so on and so forth. So the quality of life change from that treatment was immense. On the other hand, there wasn't a scale score or anything objective that we could throw back at the insurance company to show that there was a difference. It was all subjective quality of life, but it was incredibly meaningful. And so I think this is one of the challenges that we all face, is that in the attempt to have objective demonstration that a treatment or a medication might make a difference, the outcome or the positive benefit has been paired with an objective measure, such as the increase in a score on a scale. But there are not enough scales that have been validated to really show all the meaningful benefit that there are for people. And so in the whole spectrum of possible disease, there are many individuals who are at disadvantage because they don't have the exact same characteristics as those in the individual trial, and that makes it more difficult for them to access treatment. Well, I think for a core group of individuals, the ones that we have available to us do capture things that are important, but I think it's restricted to a small subgroup of the total population of individuals with SMA. I think that there are things that have to do with having more endurance to be able to, hold your posture and hold your head and hold your position, for more hours per day so that you can be out of bed and interacting in an upright face-to-face fashion with peers and family and the community. And things like that don't get captured well on scale scores. I mentioned things like endurance for using your hands to control switches and joysticks and other things like that that can provide an incredible degree of independence, and those aren't always captured really well. Everyone has been incredibly heartened by the progress. I mean, when we first started the few trials, we have to remember that just back about 8 to 10 years ago, with some of the original trials in SMA, the outcome measure was just prolonging survival by a few months. So to go from that to trying to see if infants with SMA who are treated can not only meet typical motor milestones like sitting independently and walking independently, but do it within these same age range as their unaffected peers is a very profound difference. And I think that that's the huge change that's really happened. So I think everyone, because we've lived through that, it's impossible not to have incredibly broad expectations and wonderful hopes for the future for everyone. But there's no question that having a more prolonged duration of disease before treatment was initially initiated, some of that's just arithmetic, meaning people who were born after and had a certain number of years of ongoing disease progress before the treatments were trialed and made available. So the what you might say is the incident population, those of our community who've been living with spinal muscular atrophy, who didn't have treatment available to them early in their life. I think that it's been less clear, first, whether they would respond at all to treatment, and secondly, how well they would respond and how aggressive would be appropriate in terms of trying to combine treatments and even seek additional ones. And I think that what's very important is that we make sure that the part of our community and society that funds and supports ongoing research understands that we haven't solved this issue. We haven't solved the problem, that there's really an important need for ongoing research into evaluating the benefits and the proper approach and the most efficient and least problematic, most safe way to be aggressive and provide maximal treatment to individuals with SMA who've been living with it for a period of time so that they can live their best life. These individuals usually have so much to contribute and they really deserve a lot. And there are moments where it seems as though now that we've made some really good forward progress, the pharma and NIH and philanthropy, they're sort of feeling like, well, now we've solved this, let's move on, to the next. And I think we're nowhere close to that yet. We really, really have a need to make sure that we understand in a prospective way what are the best things that we can do for individuals who've had existing spinal muscular atrophy for a period of time. As I mentioned, when the first trials, and it was with intrathecal nusinersen that most of us had the first ongoing trials, the outcome measures were simply survival. These were individuals being treated when they were diagnosed symptomatically between 3 and 7 months of age. And those individuals were very fragile for the most part. But they did so much better with treatment that as we brought them in for their ongoing maintenance treatment, we had groups of people at the hospital so that the greeters and the medical assistants and the aides that would help them, be prepared for their intrathecal treatment. They could tell which babies were being treated and which ones weren't. This one's still very fragile, and this one with the curly hair is my favorite one, and she's doing so much better. Look how they're really moving, kind of thing. It was just amazing to see right in front of you the difference that it really, really made. At that time, I didn't anticipate that we would have goals within within a decade of not only having the children make forward progress, because the rule of thumb had always been once spinal muscular atrophy is diagnosed, there would be no new gain of any motor function. None of the children ever made forward progress by the time that they were symptomatic enough to be diagnosed. So to have children make gains and begin to catch up to their age-appropriate peers gradually is just so heartwarming. It's unbelievable. Well, I think that there's two areas that we have to focus on in terms of unmet need. One of them, as I mentioned, is by paying attention to the very important population of individuals who were already symptomatic with spinal muscular atrophy and had been diagnosed before treatments were available. We now know that even with what appears to be fixed motor deficits, that people can make progress with some of these treatments. And which treatments and in what order and what's most efficient is something that really needs to be studied more over time, with careful attention to what the individuals with SMA themselves have to say, about what works and what's most important and what's not being, attended to. And then there's another kind of diversion, which would be to how can we improve our approach toward early diagnosis and early intervention and treatment? Now that we have finally, with lots of time and effort, newborn screening universally throughout the US, I think we can still make improvements. For one thing, people are beginning to investigate whether it makes a difference to know about the diagnosis even prenatally. The American College of OBGYN has recommended that all women be screened for carrier status for SMA. And then if they're positive, the OBGYNs would check the partner. And if they were positive, then testing could be initiated on the baby with the parents' judgment and cooperation and interest. But there has been very preliminary work asking and trying to answer the question, would treatment even before the baby was born make a difference? Well, that hasn't been settled yet, but is under active consideration and investigation. But one of the things that has been shown is that babies born at 37 weeks with SMA and treated as quickly as possible do better than individuals who were born at 41 or 42 weeks. So all of that's sort of within the broad range of term for infants. So their lungs are okay and the rest of their organ systems are mature enough to tolerate life outside the womb. But, again, just those, 5 weeks of difference from the earliest term healthy baby to the latest makes a difference. And so now, when we work with the maternal fetal health specialists, when they identify a baby, in the second trimester or third trimester with SMA, we've shared with them this data. And so now they tend to induce at 37 weeks rather than just waiting till whenever things happen, naturally up to 42 weeks, with the idea that if we are aware and then intervene then, that those babies do even better. So that's kind of one sort of issue. We have to solve that. But we used to think that no baby was symptomatic until 2 to 5 months of age or something. But we realize now that it really depends on two things. One is how carefully you look. And the second thing is just the variability between individual people with SMA, and we don't always understand the difference. But there's no question that there are some babies who have onset around the time of birth or within the first few months of life who have more of a challenge, more of a motor impairment than others. In other words, there is a spectrum of severity. And I think one of the challenges that we face now is what we're doing is, just the payment process and the funding for treatment tends to suggest that every baby pick one of the new disease targeted therapies. And that for some babies who have mild disease, that produces great results. But there are others that all of us who watch and see babies with SMA recognize, and that's the more severely affected motor systems in some babies, would suggest that if we could understand it a little bit better prospectively with some biomarkers, some biochemical things, some other physiologic markers and things, that we might be able to identify very early which babies need combination therapy from the beginning. And it would be very efficient if we could identify that and then use that combination therapy selectively for those who need it and not use it in those who are doing well without it. But that's all going to require additional research. Spinal muscular atrophy, the disease itself, the community that has supported individuals with that disorder has been something very special within medicine and health in the last generation. The translation of some of the basic science, the science that was done to understand this, and bringing it together and bringing it to the clinicians, and the feedback back and forth between the clinic and the basic science that has led to the development of these therapies, the development of this incredible community of support. Many individual organizations that bonded together, with the SMA Foundation and Families of SMA, which has now become Cure SMA, really worked hard to generate funding for research, and especially from some real basic seed monies for great ideas that didn't have enough data to get any big NIH or pharma funding. People who sat there and really tried to figure out what the regulatory barriers were to being efficient. I can remember being at meetings with people from all of these family foundations and community organizations where they learned that they had to be very unified in their voice. They couldn't come with one organization or another organization and try to ask for support from the Senate or the House or the state legislatures and have one comma different in their plea for help because it confused people who didn't understand the science. And after one session where some basic legislation just wanting to decrease the regulatory burden to try to contract out to small, especially academic based scientists to do some library screening for existing drugs to see if it would affect one step in the pathway. People thought it would be a slam dunk to get it approved at the federal level, and it wasn't. And afterwards, the feedback was that they had to be more like AARP. We're old and we vote and don't mess with us, kind of thing. Whereas other people had been asking for the same thing, but from with slightly different language, and it made the legislators very, very uncertain as to whether they would offend one group or the other, so they ended up doing nothing. So to have these community groups do all of that groundwork to really make it so that with reasonable amounts of money, they could get one leg up and move it from one level of inquiry to the next level of inquiry until it finally got to the point where big pharma could come in and help with these clinical trials. It happened more quickly with SMA because of the passion, the collaboration, the real hard work on everybody's part. It has been absolutely amazing, but I think I have the easiest part of the job because I'm right there and I get to see it all. I get to see I have the warm fuzzies from watching the babies that, sit and play. I mean, I have a set of fraternal twins who are now 18 months old and who were picked up with newborn screening and treated very early, who now sit there and instead of having to say goodbye to them within the first 2 years of life, they come now and dance around clinic visits and thank me for playing with them. And it just is such an incredible experience.
When Dr. Alicia Henriquez, a pediatric neuromuscular specialist at Seattle's Children's Hospital, began her training, effective therapies for SMA were only beginning to emerge. Today, clinicians are seeing improvements that were once thought impossible. Dr. Henriquez discusses how these advances have changed expectations for patients and families and why it is increasingly important to measure outcomes that reflect the real-world experiences of children living with SMA.
I am Dr. Alicia Henriquez. I'm a pediatric neuromuscular specialist. I work at Seattle Children's Hospital. I've been practicing here for the last 6 years. And I work very closely with SMA patients. We have a multidisciplinary clinic. We are involved from diagnosis through newborn screen or through the clinic, and we follow those patients until they're 21. So I'd say that when I started my training, a lot of these newer therapies were coming out. One of the reasons I chose neuromuscular is because before all of these therapies came out, a lot of neurology was just really sad, right? Like you would give this very sad diagnosis. There were no treatments. For a lot of the therapies, a lot of the care was palliative, working on improving quality of life. So when this therapy started coming out and we started seeing some, quite amazing results, it really did encourage me to want to go into a field where we had options for treatment. So that's one of the reasons I chose neuromuscular. So I'd say my expectations with the new treatments have definitely changed, right? Like I mentioned before, talking specifically about SMA, the care was palliative, focusing on quality of life, focusing on equipment and management of pain. Now, really, we've shifted to how can we treat patients as early as possible in order to maintain as much motor function as we can. And what that means for patients, for those kids who have 2 copies of SMN2, whose clinical outcome without any treatment would be, you'll be trach, you'll have a G tube, you would not be able to sit on your own. Really seeing those kids be able to breathe on their own, eat on their own, sometimes walk without assistance. It's quite amazing. So historically, the Hammersmith Functional Motor Scale has been used to assess efficacy of treatments, right? It's a statistical measure really of, is this treatment really working or not? What I presented at the MDA really focused on what does the changes on this scale really mean for patients. So some of the things that we measure are things like, being able to roll over, being able to sit with assistance, being able to hold your head up. And what, that may just be a point, which may not be statistically significant for clinical trials, but for these patients, it means a huge, huge deal. So now I think the focus has shifted to how are these treatments really affecting the day-to-day life for our patients and how they're affecting quality of life, not just for the patients, but for the caregivers as well. I think that a lot of the times when we're looking at this scores, it does give you some objective data as to like, is the patient stable or improvement? Putting things into perspective and going back a little bit, all of these treatments, we're expecting stability, right? We're not necessarily looking for improvement because we're not able to recover nerves with these treatments. We're looking for preventing deterioration or progression of disease. So we're really looking for stability. We're not necessarily looking for improvement, at least with the therapies that we have available right now. I think for clinicians, the scores are helpful because we don't have the time in clinic to do these assessments, right? These are typically done by physical therapists. So we can look back and see, oh, their score is stable, or, perhaps it's improving a little bit. Sometimes we see improvement depending on the age of the child. Or if there's deterioration, we can look at those scores and say, okay, we now have some objective data. It doesn't necessarily tell us what the day-to-day life for the patients is. So we are focusing now more, at least in our practice, like, what are the needs for the patient? How can we support you? Are you able to sit on your own? Are you on a wheelchair that perhaps is not supporting you as well? How can we adjust some of that? And are the treatments that we're providing able to sustain that level of function? We need to be listening more to what the caregivers and the patients are saying. It's more impactful for their day-to-day living. I think the scales do a good job at looking at major changes in their function, but again, it does not do a great job what those changes may mean for them. So with the study that was done before, looking at the ability to really just sit up, so you and I can have a conversation and I can look at you face to face and I can look at your facial expressions, as opposed to if you're not able to sit up, you're laying down, you're really not able to see your surroundings. You're not able to interact the same way. So we're now capturing a lot of that with the instruments that we use for clinical trials, at least. I think I really start with a message of hope. I emphasize that in the past we had no treatments and now we have more than one treatment available, and that the treatments have done really an amazing job at being able to not just maintain motor function, but improve quality of life. So my advice will always be to initiate one of these therapies. And I give families options, and every family is different because their needs are different, because their backgrounds are different. My job is to provide them with all of the information that I have and help them make a decision that works for them. Yeah, I mean, certainly, right? The gene therapy is a one-time infusion versus the other therapies that are available are therapies that require ongoing treatment for the rest of their lives. So that in and on itself, it's a big difference. In terms of, which one works better, we don't really know. We know they'll work really well. There's no trials comparing one therapy versus the other. I'd say that for our newly diagnosed kids, a lot of the families do choose the gene therapy because the data is there that it does help. There's a lot of moving pieces in terms of, do we add on more therapies after gene therapy? And do this really help? There's a lot that there is to be learned. We don't know a lot, but we know that the therapies that we have available do work. In terms of side effects, gene therapy has a lot more considerations compared to the other therapies, so it's important that families understand that as well. I mean, absolutely, right? Like I just mentioned, we don't understand how long gene therapy is going to work for, right? Because it is a relatively new therapy. So being able to understand, is this a really one and done, or are we going to start seeing deterioration years down the line? Is there really a role for, what a lot of people call dual therapy, which is adding a second therapy such as risdiplam or Spinraza? We don't have well done studies to show that this is actually beneficial, though we think in some cases, not all, but we don't know which patients will benefit from having dual therapy. And then I think a focus on, again, are there any other therapies that can help with fatigue, pain, improve quality of life? There's a lot of therapies looking at other targets like muscle rather than focusing on the SMN protein, looking at, is there a way to regenerate nerves? These are all things that gene transfer therapy was a crazy thought, right? Like 15 years ago, and now the idea of regenerating nerves sounds crazy, but is it possible? I think that sort of has been the theme today, right? Clinical trials focus on very specific outcomes, which is important to have those outcomes in order to understand is the therapy working or not. But because the therapies have worked so well, perhaps those outcomes need to be redefined to really include smaller changes that are very meaningful for families and for patients, families, and for their quality of life. I don't know of any unifying scales that will include all of the data that we're perhaps missing. So that is an area that is unmet, is trying to find a scale that includes smaller changes and includes patients' perspectives of what those changes mean. I don't know of any specific scales. It doesn't mean there aren't some, but it's also very difficult to come up with those scales because you have to validate those, and that takes time and that takes money. So I think it is difficult to just, you can't just come up and say like, now we're going to use this scale. It needs to be validated to ensure that the results will be the same regardless of the trial. I mean, I guess really just emphasizing how the SMA treatment landscape has just really changed and has continued to change so rapidly, and how when we put everything into perspective, right? Like 15 years ago, not having any treatments, and now seeing kids who would have not been able to walk without therapies is quite incredible. I call them, the miracle drugs, because it really is a miracle. It's very nice to be able to look at parents and tell them there is options, and there's hope, and there's so much that has continued to change. So that even these amazing treatments we have now are not the end of it. Like we're still working to improve outcomes and improve quality of life. So it's that message of hope means a lot. It really has changed from having to look at parents and tell them your child has SMA and this is what we are expecting will happen. I'm really sorry. It is a terrible disease, but we have this treatment options, and this is, what your child's life may look like with these treatments.
Scientific advances have transformed what is possible for people living with SMA, but important challenges remain. Dr. Angela Lek shares the patient and advocacy perspective, discussing how these advances have changed expectations for patients and families, the role of the Muscular Dystrophy Association in supporting research and care, and the priorities that may shape the future of SMA?
My name is Angela Lek, and I've been with MDA for almost 5 years now. I'm currently serving as the Chief Research Officer, where I oversee the overall research strategy, our grants program, our patient registry. MDA, as you know, is an umbrella organization. We cover over 350 distinct neuromuscular conditions, and SMA is, one of those conditions. And, we do a lot around SMA funding research, caring for SMA patients, both in the clinic and outside the clinic, provide a lot of, educational materials. And also SMA is, one of the diseases that we've been collecting data for our patient registry. SMA has really become one of the great success stories in modern neuromuscular medicine. We've gone from treating complications to treating the underlying cause of the disease with, multiple approved therapies now. If you had asked me this question a decade ago, our conversations about SMA would be largely centered around supportive care, so helping children breathe, to eat, to move, and just to maintain quality of life. But today that landscape is completely transformed, both for the patients, their families, and their treating physicians. We now have multiple disease-modifying therapies that target that underlying biology of SMA, and we're effectively now changing the natural history of that disease. So the now 4 approved therapies. These include SMN-targeted therapies such as the splicing modifiers, Evrysdi and Spinraza, as well as gene replacement therapy, Zolgensma, and more recently, Itvisma, which is an intrathecal gene therapy, expanding treatment options for older patients. So I think, the impact of families has been extraordinary. We're seeing children reach developmental milestones that weren't expected a decade ago. They're attending school, participating in sports, activities, and, they're looking ahead to careers and moving out of home. So for adults living with SMA, these therapies are helping to stabilize disease progression, preserve motor and respiratory function, and allowing many to just maintain greater independence and quality of life longer. And for the physicians, this is great. They have a way to treat these patients and to prescribe medications, life and disease-altering medications for the first time in the history of SMA. But, what is exciting is that these are the first generation therapies that target the SMN gene, but the pipeline continues to evolve. And, one of the programs I'm most excited about is the Scholar Rock drug that's in clinical trials called apitegromab. Current therapies work by increasing SMN protein levels to protect the motor neurons. Apitegromab takes a different approach. So it targets muscles directly by inhibiting the activation of myostatin, which is a protein that naturally limits muscle growth. And if this therapy is approved, it has the potential to complement the existing therapies by improving muscle strength and function in addition to preserving the motor neurons. It was shown in the phase 3 trial known as Sapphire that the patients that were already receiving the standard of care for SMN experienced even additional improvements in motor function when apitegromab was added, showing that there is still room to improve outcomes for people living with SMA. And I think this goalpost continues to shift. We're no longer simply aiming to slow disease progression. We're now asking, can we help these patients live stronger, more independent, and fuller lives? I think it's important to consult your treating physician or neurologist because every patient has a different journey, depending on when they were diagnosed, how progressed their diagnosis is. I think it's really important to see a physician that can also connect you to a multidisciplinary care clinic, which is the case of all our care centers, MDA care centers. We have over 150 of them around the United States, and we offer multidisciplinary care. So it's really important to think about the patient's well-being holistically, not just in preserving the motor neurons, but there is, respiratory care, nutrition, rehabilitation. There's so many facets to the disease that I think can and should be addressed in order to enable patients to live to their full potential. I do think it's really important for patients to continue participating in studies, particularly now that there are drugs approved to participate in post-market approval studies to gauge the durability and the ongoing efficacy of the drugs. This is going to be really informative for the field if they choose to participate in registry efforts, and also to participate in advocacy efforts linked to a patient advocacy group to make sure your voice is heard, to make sure your needs are being voiced, the needs of the community, and to align yourselves with an advocacy organization such as MDA that can represent their best interest. One of the most important lessons we've learned in SMA is that, timing of getting the treatment matters. So motor neurons, they're progressively lost before the symptoms become obvious, or even in utero. And once those motor neurons are gone, they can't be replaced. So earlier diagnosis leads to earlier treatment, and earlier treatment leads to better outcomes. And this has been reinforced across multiple cohorts globally. And that's why newborn screening has been transformational and is thankfully now happening in all 50 states in this country, and it allows infants to receive treatment before significant motor neuron loss occurs, so giving them the best opportunity for optimal development. In other parts of the world, babies born with SMAs still don't have access to newborn screening or disease-modifying therapies, but hopefully this will change over time. While disease-modifying therapies are now available and transform the outlook for individuals living with SMA, they haven't eliminated the need for comprehensive multidisciplinary care. And in many ways, these therapies have changed the questions we ask, but we haven't changed the importance of having that right team around the patient. As I mentioned, SMA affects more than muscle strength. It impacts respiratory function, nutrition, swallowing, motility, and scoliosis, and a whole host of other symptoms. And managing these different aspects of the disease requires coordinated care from specialists who understand SMA. And we have these multidisciplinary care teams positioned all across our MDA care centers across the country. Success these days and in clinical trials is no longer measured by survival or even by motor milestones. We're thinking more broadly around independence, education, employment, independent living, and real world outcomes. And, we've also learned that meaningful outcome, what constitutes as a meaningful outcome, looks different for every individual. One person's success may be learning to walk independently. For another, it may be preserving hand function so they can use the computer or feed themselves or maintain employment. And for someone else, it may just be maintaining respiratory strength or simply having energy to participate in daily activities with their family and friends. And traditional functional assessments such as the Hammersmith scale, they remain incredibly important, and they've helped demonstrate effectiveness in the approved therapies, but they don't always capture the outcomes that matter most, I feel, to patients living with SMA. And that's why we're seeing an increase in emphasis on patient-reported outcomes and other measures that reflect the lived experience of individuals. Ultimately, the goal isn't just to improve a score on a clinical assessment. It's really to help people live fuller, more independent lives. And to do that, like I mentioned, patients should participate in ongoing studies to monitor their progress. And that's where, MDA is headed to. So, one of our priorities is developing a really robust patient registry that collects these real-world longitudinal data and also patient-reported outcomes through electronic medical records and also surveys. And it's really important that we collect these real-world data on patients on the various treatment options and combinations of treatments, because this will continually inform of ways to improve care for patients living with SMA. So we've built a patient registry called MOVR, so MOVR. It stands for the Muscular Dystrophy Association's Neuromuscular Observational Research Registry. And we're currently in the process of evolving it into a next generation platform that is more patient-centered. It's called MOVR 2.0. And this version is designed to give patients and families more control over their data, enabling them to contribute information from their individual care journeys to help inform, researchers, drug developers, and so on. And as part of this, we're actively looking for individuals with SMA to participate in our pilot study. And participants can securely connect their electronic medical records, visualize their own care journey, provide feedback that will directly shape the future of the platform and MDA's research initiatives on SMA, where we also partner with, various industry partners. Enrollment is free, and, participants can opt out anytime. I think real-world data like this that we'll be able to capture is incredibly important. Even with therapies like Spinraza, we've already seen how registry data can help us better understand treatment patterns and outcomes in clinical practice. And that, that's what led to the approval of the higher dose Spinraza. And as the treatment landscape continues to evolve, having this high quality longitudinal data, will be critical in continuing to shape and guide research and care. So anyone interested can, email us at mdamovr@mdausa.org. So that is, SMA is one of the diseases that we're piloting on this new platform. Unmet needs, for example, there are some outstanding questions like durability. How durable are the current therapies over decades, particularly the ones that are, one-shot deals like Zolgensma, like Invisma? Will some patients require retreatment when it comes to gene therapies, or will they last throughout their lifetime? And also, combination therapies, can they be combined, and do they all synergize with each other? And what regimen works best for patients? We know that from looking at registry data and natural history that they don't all work the same way across patients. So I think we do need to research this on an individual basis to see who responds to what drug, in what combination, in what regimen. And, what is the best time point for treatment? We know earlier is better, but how early is early enough to prevent all the symptoms? And can treatment before any symptoms appear completely prevent the disease? We don't know that. And of course, I think adults with SMA, I think they are understudied, and there's a clear unmet need in that population, and also, with children who have been on these therapies as they age into adulthood, what does that look like? What happens over the decades? Does that stabilize their condition? Do they continue to experience the benefits of these drugs? I think although restoring SMN protein has been transformative, it still doesn't fully address all the aspects of the disease. And, there's still research to be done in terms of the muscle biology, the neuromuscular junction biology, the fatigue, how to regenerate muscles that are lost, and any downstream pathways that we can target to further improve outcomes. And this is, some areas that MDA continues to fund research. So basically, as we continue to learn more about SMA, we realize it's more complex than we once appreciated, and that this opens up like new opportunities, new areas of research. Firstly, we're moving towards combination therapies. As I've mentioned, current SMN-directed treatments have transformed outcomes, but they don't benefit every individual in exactly the same way. And the future will likely involve combining SMN restoration with therapies that target other aspects of disease biology, such as muscle health, neuromuscular function, to improve outcomes even more. And MDA has supported research exploring these complementary approaches. For example, we're funding Dr. Charlotte Sumner, who is investigating the inhibition of a protein that acts as a master regulator of axonal degeneration called SARM1. Another area of research is recognizing that SMA is not just a motor neuron disease, and low SMN levels affect other tissues, including skeletal muscle and even metabolic organs such as the liver. So MDA has supported Dr. Umrao Monani's work, showing that even low levels of SMN within the muscle itself can drive muscle pathology independent of motor neuron loss. We're also funding Rashmi Kotari's research, correcting SMN deficiency in the liver that can improve metabolic abnormalities in SMA models. And so, it goes to show that we may need to treat and think about organ systems just outside the neuromuscular system. And also we're funding research aimed at understanding the earliest stages of the disease. So MDA is supporting Dr. Rodriguez Muela, who is using stem cell and organoid models to understand very early developmental changes associated with SMA and identifying new therapeutic opportunities there. And I think the future of SMA will involve a comprehensive approach combining these SMN restoration therapies that have been approved, and then ones that support the muscle health, protecting other vulnerable tissues and organs, and addressing developmental changes. And this is the kind of research that MDA is committed to supporting, because there is still room for improvement. We continue to fund basic science research, and we have, since our inception, MDA has invested over $50 million in SMA research. So we're training also the next generation of scientists who have an interest in SMA research and funding them also.
The story of spinal muscular atrophy is one of extraordinary scientific progress made possible through the efforts of researchers, clinicians, advocates, patients, and families. While important questions remain, the advances of the past decade have fundamentally changed what is possible for individuals living with SMA and have challenged us to rethink what we define as a successful outcome. Thank you for joining us for these expert perspectives.